Welcome back to the deep dive. This is where we take your source material, could be notes, articles, anything really, and basically pull out the key stuff for you. Give you that high yield summary, kind of a shortcut through the noise.
Exactly, your personal briefing.
And today we're diving into chronic kidney disease, CKD. The source we've got here looks like a really solid set of revision notes, seems designed for a clear, quick overview.
That's right. So our mission today is to break these notes down for you, hit the core facts on everything from the definition, the causes, how it presents, right through to management. Really give you that high-yield understanding straight from this material.
Perfect. So whether you're prepping for exams, need a clinical refresher, or honestly just want to get your head around a major health condition, this is for you. Okay, let's get into it. First things first. What exactly is chronic kidney disease, according to these notes?
Okay, so the core definition here is a progressive and crucially irreversible loss of kidney function. It's not sudden, it develops over months, sometimes years, and the diagnosis hinges on two main things. Either evidence of actual kidney damage, the notes highlight albuminuria, so protein in the urine, or a decreased estimated glomerular filtration rate, the eGFR.
And there's a specific number for that eGFR.
Yeah, it's getting below 60 milliliters per minute per 1.73 square meters. But the key thing for it to be chronic is the time frame. Either that damage marker or the low eGFR, it needs to be hanging around for at least 3 months.
3 months, that's the magic number for chronicity.
Exactly. That duration separates it from, say, an acute kidney injury.
Makes sense. Now, the notes also mention something called accelerated CKD. What's that about?
Right. So accelerated CKD is when things are declining much faster than usual for chronic disease. The definition they give is a sustained drop in GFR of 25% or more, plus a change in GFR category, like going from stage 3A to 3B, all within 12 months.
Okay, so a significant drop in a year.
Or, simply put, a sustained drop of 15 milliliters per minute within a year. It flags that things are moving quickly, needs closer attention, probably specialist input.
And I see the notes stress catching CKD early, especially in primary care.
Absolutely. Early intervention is critical to try and slow down that progression, whether it's typical CKD or this accelerated form.
Okay, so detection is key. Once it is detected, how do these notes say we should classify it? How severe is it?
Well, the classification is mainly based on that eGFR number we talked about, but it's also combined with signs of kidney damage. The eGFR itself, the notes mention, is usually calculated using formulas like the MDRD equation uses creatinine, age, sex, that kind of thing.
Right.
Then you get the stages. Stage 1 is actually a GFR over 90, so technically normal or high, but there has to be other evidence of kidney damage.
Ah, okay, so GFR alone isn't the whole story in stage 1.
Exactly. Stage 2 is a mild decrease, 60 to 89, again with damage signs. Stage 3 is moderate, and it's split. 3A is 45 to 59, 3B is 30 to 44.
Okay.
Stage 4 is severe, GFR 15 to 29, and Stage 5 is less than 15. That's basically established kidney failure or end-stage renal disease. Often needs dialysis or a transplant.
Got it. So for those early stages, stage 1 and 2, what counts as those signs of kidney damage if the GFR might still be relatively decent?
Good question. The notes list a few key things. Persistent protein in the urine, that's the albuminuria or proteinuria we mentioned. Also persistent blood in the urine, hematuria, that isn't caused by something else obvious. Structural problems you can see on scans, like polycystic kidneys, or, if a biopsy has been done, proof of something like chronic glomerulonephritis, basically, ongoing inflammation in the kidney filters.
Okay.
But what these notes really emphasize, and it's a crucial point for understanding risk, is looking at the eGFR and the albumin to creatinine ratio, the ACR, together.
Ah, the combined assessment.
Exactly. It's not just the GFR stage. How much protein is spilling into the urine is a massive independent risk factor. Higher ACR plus lower GFR equals much higher risk. They kind of multiply each other's effect. It gives a much better picture of the patient's overall risk profile.
That's a really important takeaway looking at both GFR and ACR. So this progressive damage, what's actually causing it? What are the common culprits listed here?
Well, the notes list the big underlying conditions, things like diabetes, high blood pressure, hypertension, glomerulonephritis, polycystic kidney disease, which is often inherited, and various autoimmune diseases.
And do they narrow it down to the most frequent ones, like a top 5?
Yes, they do. The top 5 listed specifically are, number 1, diabetic nephropathy, kidney damage from diabetes, then chronic glomerulonephritis, chronic pyelonephritis that's often from repeated kidney infections.
Okay.
Hypertension, high blood pressure damaging the kidney vessels over time. and adult polycystic kidney disease. These are the ones you see most often leading to CKD.
Knowing those causes helps pinpoint who's most at risk. What risk factors do the notes highlight?
Right. The key risk factors listed are having diabetes, having hypertension, those are the big two.
Yeah.
Also, older age, having a family history of kidney problems, obesity, smoking, having existing cardiovascular disease,
Yep.
and certain ethnic backgrounds. The notes mention African, Asian, and Hispanic populations having higher risk.
So if you tick several of those boxes, screening becomes more important, presumably.
Definitely. It connects right back to why early detection and investigations are stressed. If you have these risk factors, you should probably be checked.
Makes sense. Let's talk about the mechanism. What's actually going wrong inside the kidneys, the pathophysiology?
The core issue described here is progressive nephron loss. Nephrons are the kidney's little filtering units. In CKD, these get damaged and die off over time, and unfortunately the kidney can't just make new ones.
So you just lose filtering capacity.
Pretty much. And that loss leads to the overall drop in kidney function. The notes mention the underlying processes driving this damage include things like chronic inflammation, oxidative stress damage from free radicals, essentially fibrosis, which is scarring.
Scar tissue building up.
Yeah, replaces functional tissue, and also impaired blood flow within the kidneys themselves.
And the consequences of losing that function, what happens in the bottle?
Well, the notes list the main ones. You get fluid and electrolyte imbalances because the kidneys can't regulate sodium, potassium, water balance properly anymore.
Right.
Waste products build up in the blood. That's uremia. And this leads to all sorts of systemic complications affecting other parts of the body.
Okay, so given that the early signs can be minimal, how do you differentiate CKD from something more sudden, like an acute kidney injury? What are the differentials?
That's a key distinction the notes address. Comparing CKD and AKI, CKD usually has symptoms going on for longer. Patients might mention nocturia, getting up at night to pee, which suggests a longer-term issue.
Okay.
There's typically no obvious acute trigger, like a bad infection or dehydration causing AKI. Also, patients with CKD might already show signs of chronicity, like anemia or high phosphate levels, though labs can look similar in AKI sometimes, so you have to be careful. A big clue often comes from ultrasound. In CKD, the kidneys might look smaller, scarred, with thinner cortices, the outer layer. Though there's a caveat. In diabetic kidney disease, the kidneys can sometimes look normal-sized or even big, especially early on.
Interesting exception. And what about acute on chronic?
Yeah, that's when someone with existing CKD gets a sudden worsening. Maybe they get an infection or dehydrated or start a new medication that affects the kidneys. So their baseline kidney function was already low, and now it took an acute hit. Important to recognize because you treat the acute trigger differently.
Got it. Stepping back, how big a problem is CKD? The notes give some UK figures.
Yeah, they estimate around 3 million people in the UK have CKD, and it gets much more common as people get older.
Wow, 3 million. That's significant.
Hugely significant. It's labeled a major public health concern. High healthcare costs, a leading cause of death and disability. And the notes also mention variations based on ethnicity and socioeconomic status, so there are health equity issues involved too. It's a massive burden.
Okay, so it's common and serious. What does it actually feel like for a patient? What are the clinical features?
Well, the first point the notes make is that early stages are often completely asymptomatic, silent.
Which is why screening those risk groups is vital.
Exactly. It often gets picked up incidentally on routine blood tests for diabetes or hypertension monitoring, for example.
But when symptoms do show up, usually later on.
Right. In more advanced stages, when function is really dropped, you start seeing things. The list includes fatigue, just feeling wiped out, fluid retention, causing swelling edema, often in the legs, ankles, sometimes around the eyes, increased urination, especially at night, that nocturia again, loss of appetite, feeling nauseous, maybe vomiting, muscle cramps, itching, which can be really bothersome, pruritus, bone pain can occur, shortness of breath, sometimes a specific smell on the breath, like ammonia, uremic zitter.
Right, from the waste buildup.
Yeah, and in very advanced stages, you might see cachexia, muscle wasting, restless legs, and obvious signs of anemia like pallor and more shortness of breath.
That's quite a list, all stemming from that loss of filtering and balancing functions. So how do we confirm the diagnosis and keep track of it? What investigations are key?
Okay, investigations. Blood tests are central. You're checking serum creatinine to calculate the eGFR. And again, confirming the eGFR is consistently below 60 for over 3 months is key for diagnosis. You also check electrolytes, potassium, phosphate, calcium, etc. for those imbalances.
And urine tests?
Absolutely crucial. A basic urinalysis dipstick can pick up protein or blood, but quantifying the protein, specifically using the urine albumin to creatinine ratio, ACR, is essential. Like we said, it's needed for staging and for that risk assessment alongside the eGFR.
Okay. What about imaging?
Kidney ultrasound is common. It looks at the size, shape, structure of the kidneys, can show scarring, cysts, blockages, things like that. CT scans might also be used, and sometimes the less common, a kidney biopsy might be needed to figure out the exact cause of the kidney damage or how bad it is.
Right. And how does screening and monitoring fit in?
Well, screening is for those at-risk groups we mentioned, people with diabetes, hypertension, family history. They should get regular eGFR and urine ACR checks. Once someone's diagnosed, monitoring involves tracking that eGFR and ACR over time. How often depends on their stage, how fast it's progressing, other health issues. The notes mention following guidelines like NICE recommendations for the frequency.
Okay. And when does someone need to see a specialist, a nephrologist? Are there clear criteria?
Yes, the notes list several referral triggers. Generally, if the GFR drops below 30, that's stage 4 or 5, they should be referred. Other reasons include a high or rapidly rising ACR level, a fast, sustained drop in GFR, that accelerated progression we talked about, blood pressure that's really hard to control even with multiple medications, if a rare cause is suspected, or if there's concern about renal artery stenosis, narrowing of the kidney arteries. And importantly, the notes add that you always consider the patient's individual wishes and their other health problems when making that referral decision.
Makes sense. And there's a list here of additional investigations, too.
Yeah, these are things that might be done in specific situations. Looking deeper into causes or complications includes tests like serum urea, glucose, sodium, potassium, bicarbonate, calcium, phosphate, cholesterol, full blood count for anemia, iron studies, sometimes specific autoimmune blood tests, and more detailed imaging if needed. They help build the full picture.
All right, a lot goes into diagnosis and monitoring. Now, the really big question, how is CKD managed? What do these notes say about treatment?
Okay, management. It's comprehensive, aiming to slow things down, manage symptoms, prevent complications. The notes break it down into prescribing and non-prescribing approaches.
Let's start with prescribing. What medications are key?
A major focus is cardiovascular risk reduction because heart disease risk is so high with CKD. So number 1, blood pressure control. Really tight control, often with specific targets depending on their ACR level. ACE inhibitors or ARBs are usually the first choice, especially if there's protein in the urine.
And you mentioned monitoring potassium with those.
Yes, absolutely crucial. Need to keep an eye on potassium levels. Also, managing blood sugar tightly in diabetics and using statins to control cholesterol are standard parts of reducing cardiovascular risk.
Okay. What else on the medication front?
SGLT2 inhibitors get a specific mention. These are relatively newer drugs initially for diabetes, but now shown to protect the kidneys. They're considered for people with both diabetes and CKD if their ACR is above a certain level. Dapagliflozin is specifically named as an option depending on eGFR and diabetes status.
Interesting. What about managing other CKD issues?
Managing high phosphate levels is important for bone health. This often involves dietary advice first, then phosphate binders pills taken with food to stop phosphate being absorbed. And then for people who reach end stage, stage 5, it's renal replacement therapy. That means dialysis, either hemodialysis or peritoneal dialysis, or a kidney transplant, which is the preferred option if possible.
Okay, that covers the main prescribing aspects. What about non-prescribing? Lifestyle, diet?
Hugely important. Lifestyle changes are key. Regular exercise, maintaining a healthy weight, and definitely stopping smoking. Nutrition is critical. Dietary advice needs to be individualized, but often involves restricting protein, phosphate, sodium, and sometimes potassium. Getting enough calories is also important, so nutritional supplements might be needed.
Right, it's a careful balancing act.
It really is. Then there's managing the specific complications, addressing fluid overload, often with advice on limiting fluid intake. Managing the mineral and bone disorder side involves those phosphate binders, sometimes active vitamin D supplements. The notes also mention treating osteoporosis with bisphosphonates, but basing the decision on trends over time, not just one reading.
Okay.
Managing acidosis, which is common, might involve taking oral sodium bicarbonate supplements. And for that difficult symptom of itching, pruritus, in dialysis patients, the notes recommend a specific drug, diflucombalin.
So it's a really holistic approach, tackling it from all angles. Given all this, what's the general outlook? What does the prognosis section say?
It says prognosis is very variable. Depends heavily on the underlying cause, what stage it was caught at, and how well everything is managed. The good news is that early detection and good management can significantly slow down the progression for many people.
But it can still progress.
Yes, it can still progress to end-stage kidney disease needing dialysis or transplant.
Mm.
And having moderate to severe CKD significantly increases the risk of other bad outcomes, especially heart attacks and strokes. The notes reiterate that rapid progression, that GFR drop over 25% or 15 millimol per year, signals a worse prognosis. And prevention, they stress again, relies on early diagnosis and controlling those root causes like diabetes and hypertension.
And finally, the notes loop back to complications, just to summarize them.
Right, just reinforces the main things that go wrong as a consequence of CKD and need active management. That's the fluid and electrolyte imbalances, the high blood pressure, cardiovascular disease itself, anemia, the bone problems, neurological issues like itching or confusion in severe stages, and malnutrition. And the management points we just discussed are how you tackle each of those complications directly.
Okay, wow. We've really covered a lot of ground there, walking through these CKD notes from the definition, staging, causes, right through presentation, diagnosis, management, and outlook. It's clearly a complex condition with major implications.
It absolutely is. And I think when you put all those pieces together, the fact that it affects millions, it's often silent early on. It causes so many complications, and it's a leading cause of mortality.
Mm.
It does make you think, doesn't it? It sort of raises the question, how much difference can we really make by focusing super hard on that early detection, aggressively managing the risk factors like blood pressure and diabetes, and applying all these management strategies consistently? Understanding these notes isn't just academic. It's about grasping the potential to genuinely change the future for so many people affected by CKD.
That's a powerful thought to end on. Hopefully this deep dive has given you, our listener, a really clear, high-yield summary of chronic kidney disease based on this source material.
Yeah, hopefully reviewing these key points helps cement your understanding.
And look, if you did find this useful, maybe for revision or just general knowledge, the source material seems related to resources you might find helpful. Check out passthemsa.com and freemsoa.com if you're looking for that kind of thing. All right, that's it for this deep dive. Thanks for joining us. Bring us your next set of notes or articles, and we'll unpack them together soon.